I now invite Professor Rema DOGRA for his talk on lessons on managing retinopathy of prematurity. Over to you, sir.
Thank you for the opportunity, Dr. Amit and Parul. I think my favorite subject, my third talk on ROP today, so which is sort of a record for me also, which I never did, 3 talks in a day. These are my disclosures. Basically, I think what we learned by experience and was something of a great education to us, that retinopathy of prematurity is emerging as the leading cause of childhood blindness in our country. And this happened especially when we noticed long time back that higher birth weight and heavier babies and older infants are developing ROP, which was not known. I think that was Anand Vinekar's thesis which led to that. And I think we were all following Western guidelines, missing a lot of babies, and they were going blind. And so we thought we need to have our own guidelines. So you can imagine how the guideline changed to 2 kgs and 34 weeks. That is what we have to follow, and that is what is important, not what is from the you can see here guidelines from the USA, where 1530 weeks are the guidelines. And what is important is, I think we have to also propagate this, that this is 30 days, within 30 days, 3 to 4 weeks, eligible infant must be examined. And the examination should be a dilated exam. And this slogan has been given also by our alumni, Tees Din Roshni Ke, by Subhadra, who's very passionate about it. And we have a real issue with a lot of special newborn units in this country. Practically every district, more than 800 opened already, where we are getting stage 5 from these places. So I think all the more, if we can propagate and they can send them somewhere, we'll be doing a great job. So anybody who knows indirect ophthalmoscopy and little bit about ROP, they can do this, but we have other like RATCAM and wild field screening as well as smart-based. And of course, Anand did teach about that non-ophthalmologist can do it with his different cameras and certain cheaper cameras available these days. And another issue is that we must document them uniformly. We were very lucky. This was one of the first diseases where the international classification was initially started in 1984 and revised so many times till 2021. And the current treatment which we have to, I think, again propagate and is very important, that we have to talk to our people, especially our pediatrician, neonatologists and others, that they have to do this good monitoring of oxygen level and nutritional status. And we still have peripheral ablation with laser at a standard of care. Anti-VEGFs are coming in big way, and surgery is needed for 4 and 5. I think what is done is that you do a laser, confluent laser, with a laser indirect ophthalmoscope, 90%, and this was done with diode. We had to procure diode. We were not permitted with any other laser. But we, when our diode conked off long time back, we treated with 532 laser. We presented this even in American Academy as a poster. They took undertaking from me. I still remember that we are doing something wrong. So you can imagine. But this has become, I'm very happy, this is a big contribution from our center, that now everybody does with 532 lasers, the same laser which is being used for other retinal diseases. So this was something which we could, and this is one such baby here, so we don't need a separate laser for that. So anti-VEGFs are coming in a big way. We know that they are slowly becoming more and more acceptable and an easy way. The people are not ready to do laser. It's a difficult proposition. So most would use for aggressive ROP and zone 1. And anti-VEGF injection once given, we wait for the vascularization till the time it has reached wherever. So you'll do less laser, less destruction of retina. But the problem is late recurrences and the systemic effects. And of course, the problem we must remember, if you have done injection, then be prepared for long-term follow-up. It's a real problem. Otherwise, they can develop recurrence suddenly and you can lose the eye. And surgery, of course, we have stellar buckling, which is rarely performed, but still in some cases. But lens-sparing vitrectomy is something which one must learn. And this is something which has done wonders in recent time. Lensectomy vitrectomy for stage 5 is something which is not that sort of a rewarding, but still I congratulate all of them, those who do it. Maybe some get sort of a ambulatory vision. But lens-sparing vitrectomy is something which we must all do, and we can give very rewarding results in many of them. And this is one such case. I think this I operated sometimes in 2017, I still remember, came late, and we did laser, but it was already proliferating, went to stage 4B. You just go in, cut that, and the retina would go back. Otherwise, you can imagine how angry looking it is. And stage 5, of course, is something where we don't want them to go, because that is where we want to prevent them from going, because they lose everything once they go there, and they have usually a poor result. So I think the prevention of blindness from ROP is the most important thing, and it should be reduced with the excellent neonatal care. Have a collaboration, good collaboration with SNCUs, with the NICUs, with other areas, wherever you work, later on you go. And the timely detection of ROP. You must have that timely screening so that treatable stage is picked up in time and you can manage it very well. I think we have shown in 2 studies I quoted here. One is from our center. I had given thesis 20 years back. So gave the same thesis again. So can you imagine that time in the beginning, the first thesis, not that many lower birth weight babies were surviving. Later on, even very low birth weight. But despite that, the incidence came down from 47 to 22%. So you can imagine that is what difference you can make if you do that kind of a thing. And Anand has also shown the same thing in another study from there. So I think the rest is the concluding slide. I think ROP blindness is preventable in the majority of cases. We have an issue, and higher birth weight babies develop severe ROP in India. And screening is the most important, as I mentioned, according to guideline, country-specific guideline, and manage all cases promptly with laser and anti-VEGF. Lens-sparing vitrectomy, send them early at 4A, stage 4A, 4B. They'll do much better. Don't let them go to 5. And the vitreous surgery, although done for 5, has a poor outcome. So major problems still remain: suboptimal care, for which you have to collaborate, and also delayed screening in our country. Thank you very much.
Well, thank you, sir, for such a wonderful talk. And I think sir has been instrumental in so many of the very relevant conclusions, most important being that higher birth weight babies can also develop a severe ROP besides other interventions. And any questions for sir at this stage? Any questions?
Thank you.
Thank you, sir.